Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. Sitting here with you. What could be better?
Yeah, another weekend morning in St. Louis. When this drops, it'll be the end of May, and hopefully getting into more consistent weather patterns. It's been kind of hot and cold here in May, so looking forward to more consistency. And then we'll be complaining about how hot it is.
That's right. But I don't think it's just us. My daughter's in Boston, and I think it's freezing now, and flowers haven't bloomed apparently. And so I think these weather patterns are going to continue.
It's almost as if something was changing with the climate. I wonder.
No, no. Silly, silly. We have a good show. We have three different things to talk about, but I think it's packed.
Yeah, so you've got a case that you want to run through. I actually have a case I could slide into. We got a great email from a friend and listener, Rob Gray in Chicago. And then we have our, I think it's quarterly Journal of Hand Surgery Journal Club, which would prove to be a big hit last time. So hopefully it continues to live up to its past success.
Absolutely. Yeah, we should probably stop the banter, even though everyone loves our banter, I'm certain, and jump right in.
Absolutely. So why don't you tell me about this case that you got?
I knew I told you earlier it was nerve, and you got all excited.
Yeah.
Um, so, a delightful 52-year-old woman comes in the office. She has isolated right upper extremity complaints, and really her complaints are night awakenings, numbness in the thumb, index, and middle finger, some electrical sensations. And I'm like, okay, good. I needed a straightforward carpal tunnel today. So after talking to her and making up my mind that I know what she has, I did the exam. And she has carpal tunnel provocative signs. Um, she had negative cervical signs, negative pupil tunnel signs, but she has a very hot pronator irritated nerve. So her median nerve
Really?
in the proximal forearm was very irritated. And, I tried the elbow extended resisted pronation test to see if that made it worse. It did not. And so, a couple of things. Number one, in the first scenario, do you still get nerve studies? Meaning, if it's just carpal tunnel and clicks, checks all the boxes, CTS6 is clearly positive, do you still get nerve studies? And would this presentation potentially change or definitely lead you to nerve studies to assess the pronator?
So a couple of points that are really interesting in there. The first question I have is, does this patient have a muscular forearm? So like I found in laborer type people or just really muscular people, the forearm becomes a more common source of compression. Or is this a more slender person? Maybe a Goldfarb D kind of build.
She would fall into our category rather than the muscular type.
Got it. Got it. But I still look. It's still part of my assessment. To your first question, I think largely shaped by what you taught me and as well as our partners. If it's a straightforward carpal tunnel, CTS6 through the roof, classic case with provocative signs, and no question about neck involvement, no question about ulnar nerve involvement, then no, I don't get nerve tests and I don't even get an ultrasound anymore. I think an ultrasound might be a nice way to demonstrate to the patient that they have something going on. But usually the way I ask about that is, do you have anything shooting from your neck? And does your pinky ever get involved? And if they say no to both of those things, and then the Sperling's is negative, and then they nothing provocative at their elbow for the cubital tunnel, then I'll go ahead and say, all right, let's move forward if you would like. I'm happy to get nerve testing if you would like, but it would largely be confirmatory, and it wouldn't change what I'm going to recommend because it looks like a textbook case of carpal tunnel. I found that language like that typically, assuages any issues about, well, he didn't even get a test, etc. But if there's any concern for cubital or neck involvement, I will then get a test. Now, with regards to forearm compression, our friends at Mayo Clinic, I think this paper was led by Alex Shin, looked at whether you can actually isolate pronator teres from pronator quadratus based on elbow position, because the classic teaching is that you can, but they found that you actually can't with localized DMG, dynamic EMG. So I still test as such, but I'm less optimistic that it actually helps me determine so. I think that the key test for me is point tenderness. Not point tenderness. Doing a provocative test where I push on the Lacertus or FDS arch area, and there are distal paresthesias. That coupled with any actual AIN weakness, so weakness in FPL, for sure is going to get a proximal forearm release. If it's just provocative symptoms, then I could say, hey, I think there's something going on here. You have the choice of doing both carpal and releasing in the forearm, or we could just do the carpal tunnel and see how you do. The advantage of just doing the carpal tunnel is that you can be completely awake, and it probably is going to put out the fire enough where you don't have to have anything done. But if you want to be one and done, we can do both on the same day. But you'd have to put you to sleep because I don't like doing wide awake for proximal forearm releases.
Interesting, interesting. Yeah, so this woman just had positive percussion over the um, FDS arch, really. No real pain, certainly no weakness. And so I chose the path of recommending a carpal tunnel alone. I didn't really go down the path of make a choice. It'd be interesting to see. Hopefully, I can remember to bring follow up. But my gut is just carpal tunnel with an irritated nerve, more proximally. Is that
Do
crazy?
you ever? No, I think that's very reasonable. Do you ever do a steroid injection in this setting at the carpal tunnel to see what that does for you?
I did offer that. I started to do more and more ultrasound guided steroid injections, not personally, not for a carpal tunnel. I don't use in the hand. The only place in the hand where I use ultrasound guidance is STT joint. But I think for pronator, I think occasionally for cubital tunnel, and I think for distal biceps, I've now started to do more of those with ultrasound guidance.
What's your first? I want to talk to you about your thoughts on steroid injection for cubital tunnel because that comes up every now and then, and I kind of have come to my own thoughts on it, but have seen some conflicting literature. But your earlier point about nerve testing for the pronator, I actually don't think it helps very much. I don't think you can truly get a good sense of compression in the proximal forearm with your nerve tests. I've often found those to come back as quote normal. So that's a clinical diagnosis for me. And an ultrasound guided injection would be helpful. And then I think we've said this before on the pod, but I don't actually think it's the Lacertus or the pronator that's the source of compression. I think it's the FDS arch. So my
Totally
current
agree.
approach is release the Lacertus to get to the FDS arch, release the FDS arch, and then I can insert my entire fat finger, as some people say, uh, along the course of the nerve. And if I can do that and hit the radius, there's no way that the actual pronator teres is the compression point. Because taking that down has much more morbidity and higher hematoma risk. And I think this is, doing a proximal forearm median nerve decompression is one of those surgeries to me that has hematoma risk all over it. So you just have to be mindful of that.
Totally, totally agree with everything you said. Yeah, I kind of think of um, Coronary syndrome like radial tunnel in the sense that nerve studies just don't help me in that diagnosis. Both to me are completely clinical diagnoses.
Now, I will use an ultrasound guided steroid injection much more frequently for radial tunnel because I do find that to be quite effective. For some reason, I just
Effective diagnostically or effective to make them feel better temporarily or longer?
both. Both. So as much I send a lot of people for that injection, just because I don't want to deal with doing that in clinic, to be honest with you. And am I in the right place? Am I not in the right place if I do it without guidance? Um, I've found that to be more effective than sending them for an injection for median nerve decompression in a forearm. I don't know whether it's just because I think I can do that with, minimal morbidity, or it just doesn't come up as much. I'm not sure.
Yeah.
So you bring up the point about a steroid injection for cubital tunnel. Now, I wondered this when I was early on, like why aren't we doing more of this? I don't know if it's a bias because we're surgeons, and have kind of wrapped my head around the fact that the pathophysiology of cubital tunnel is different than carpal tunnel. So in carpal tunnel, you just have swelling within a confined space, chokes off the blood supply to the nerve. Taking the swelling down of the surrounding structures will make more space for that nerve. In cubital tunnel, you not only have that element of compression, and in this case, in cubital tunnel, it's between the heads of the FCU, but you also have the element of traction. And Dr. Gelberman and Dr. Yamaguchi's paper showed how that extraneural and intraneural pressure skyrockets as the elbow flexes, and that traction moment gets worse. So, steroid injection isn't going to make the traction change at all. It might take some of the swelling down around the FCU heads, but I don't think the FCU heads are actually swollen. So I don't find this to be a surrounding things are swollen. Let's do a steroid injection and make it better, which is why I have not used steroid injections for cubital tunnel. But I do know in that hand surgery evidence update that you put me onto, there was a paper or a systematic review demonstrating that steroid injections are effective treatment for cubital tunnel. So maybe I'm wrong. What do you think?
I think there's two considerations. First, our practice, and that's globally, we don't do a lot of cubital tunnel decompressions. To your point about the role of traction, I will do them occasionally. I did them more in the past, but with my younger population, I haven't found to be very successful. Theoretically, that only addresses the compression concept, which could be addressed as well with a steroid injection. But for me, this is done when I have often, give you, the typical is a young thrower with medial elbow pain, occasional tingling, no clear UCL issue, no clear physeal issues or anything else. So it seems like it's the nerve, but I use it diagnostically more than I use it therapeutically.
Do you think it's more a swelling issue at the flexor pronator mass? Because I mean, and then where are you asking them to put the injection? So if you send it, like I actually sent somebody for an injection because there was specific focal swelling on the ultrasound at the F's between the FCU heads. It wasn't behind the medial epicondyle at the cubital retinaculum. It was actually between the FCU heads. So that's the first time I've ever sent anybody in the last 7 or 8 years for a cubital tunnel steroid injection. So where do
Yeah,
you think the swelling is?
well, which I would maybe slightly different than what you're asking, but I think the problem is cubital retinaculum and FCU entrance for me the vast majority of the time. So I actually have not specified in my mind, and maybe I've had a conversation with a couple of our physical medicine rehabilitation doctors. I like it actually slightly proximal to the cubital tunnel. I don't want them injecting into the cubital tunnel per se, but maybe I'm thinking about it wrong.
Yeah, I guess I mean, sometimes you do, obviously on the ultrasound, you see swelling of the nerve, and maybe the point of the steroid injection is to bring down the actual swelling of the nerve. But I'm not sure how much of that is an inflammatory process at that point when the nerve is swollen, as more of a reactive kind of enlargement of the nerve or flattening of the nerve at increased diameter.
Yeah. Well,
Sorry, we
here's what
really went deep on this one.
I would say here's what I hope. I hope our listeners are going to share some of their knowledge with us. Email us and let us know what you think and how you handle this because we'd love to share some of your pearls with the rest of our listeners.
So absolutely, please send us those at handpodcast@gmail.com. We should say that the upper hand is sponsored by practicelink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job does not have to be. Join Practice Link for free today at www.practicelink.com/ the upper hand. Speaking of listeners submitted thoughts, we have some good ones.
Yeah, so our friend Rob Gray in practice in Chicago has been talking, sent us an email about this OR efficiency episode that we did a while back and Chuck's trip to Atlanta where the players play. And he's looking at setting up a procedure room himself. And we are actually at that same point too. And the question is it better to use disposable instruments for each case versus sterilizing reusable instruments, which at first sounds like very wasteful to use disposable instruments. But then you think about how many instruments do I really use? What's the water consumption of actually sterilizing, washing and sterilizing these things, water and energy versus just buying instruments for each case? So that really kind of caught me off guard. What do you think about this, Chuck?
I think it's a fascinating topic, and we need to find an expert and bring them on and dive deeper, honestly, because I think you and I both are very interested in this just because we're interested in this and because it applies to some of the planning we're doing at a new site. Um, we could go so deep on this. There are examples, I think in Europe, these kind of disposable instrumentation cases are more commonly utilized. That's number one. Number two, the Exomed screws, which were purchased by Acumed, when those first came out, they were in a disposable pack, everything you needed, and everything got tossed at the end of the case. And so, for me, someone who considers myself pretty green in how I approach life, from my car to my solar to all those things, this matters. And if we can do our small part, we should. But I don't know the data and You and I, during COVID, we did more local only in the office than historically we have. And we did experiment with some disposable instruments. They're not as good, um, clearly not as good, um, but they're good enough. I guess I don't have too much of a challenge in using them. I don't know.
I would I am very direct with our OR staff when my tenotomies aren't cutting. And if it's a me thing, then it's a me thing, but it's definitely the tenotomies when they don't cut the tissue they're supposed to cut. And I immediately ask them to be marked for sharpening. I think I'm going to go crazy if I have to use disposable instruments that are of not good quality. So obviously, you're going to get what you pay for. And where is that threshold where it works out? I don't know. And I'm not sure. I obviously would need to test these puppies out in the lab before wanting to move forward with using them in patients. But even it comes down to like drapes. During COVID, one of the medical students who rotated with me needed a QI project to work on, and she was very efficient in helping pare down our local only drape pack. And it became not only more environmentally efficient or environmentally appropriate, but also cost effective. It was the cheapest drape pack in the system, and that's what you and I used in the office when we had our second shutdown and we're doing cases in the office. But it gets to the point of like you go to other countries and they reuse the drapes. So that kind of makes sense, but then you have to wash the drapes and like then the water and everything that probably isn't very environmentally friendly. It seems wasteful. So I'm not sure what exactly the right way to do it is. And then as we're setting up our new site, we have to have a conversation with our partners saying, do we really need this to be fully sterile? Or can it be a clean procedure, much like what Dr. Lalonde does in Canada? So there are a lot of principles that we just need to reevaluate. And, I'd love to have somebody on who is an expert in green surgery. I know there have been some papers in JHS on that recently.
Yeah, it's a great topic. It's a fascinating topic that really is applicable, especially with CMS changes to site of service and reimbursement for physicians. That's a factor. I'll say it like I feel it, doing the right thing for not only the patient, but for society. It's interesting. I mean, clearly, I think a lot of listeners are rolling their eyes saying, you guys are late to the game. And maybe we are, but every institution has its own issues and discussions around these things. And there's so many local variables, not local only, local geographic variables that, it is what it is, better late than never. And I think we need to have some good conversation about this.
Yeah, for sure, we're late to the game. So thank you to Rob for that email and thought-provoking point that you make about instruments. So why don't we move into our JHS Journal Club? Before we do, we should say that our sponsor, Checkpoint Surgical, is supporting the peripheral nerve course this coming weekend here at WashU in St. Louis. It's shaping up to be a great program, and we're really looking forward to it.
You can learn more about Checkpoint Surgical and their product portfolio at checkpointsurgical.com. Yeah. Is it so? This episode is going to drop, the weekend before, the Sunday before your course.
Yeah, I mean, everybody I'm sure is barbecuing for Memorial Day and listening to the upper hand. Or if you're like a fantastic resident of ours, Carson Bailey, you're mowing your lawn and listening to the upper hand on a Sunday. Just good old time.
Yeah. Well, I know it's going to be a great course, and we're grateful for Checkpoint Surgical, who seem to be doing a lot of support for things like this. But so we're grateful. So we have 5 articles to discuss that were selected for us. We did not pick these, so we're grateful. I mean,
Thank
I'm
you
not
for
saying
picking
anything.
them. It seems like you're putting a disclaimer in
No,
there. Thank you for
no
picking them, Nash
disclaimer.
and Macarena.
Yeah, Nash and Macerena, thank you. No, I think you and I were very clear that, we wanted others to select the articles for our discussion, and that's what we've
Just
done. So,
otherwise, it would just be congenital and nerve alternating. Maybe some sports in there.
yeah, exactly. All right, you want to start with the Keen box one?
Yeah, so this is only a few centers can do a paper like this with a 40-year experience with any conditions. So Steve Moran at Mayo Clinic led this effort, and it's a 40-year retrospective evaluation of vascularized bone grafting for Kienböck disease. Now, our partner, Dr. Boyer, would say vascularized bone flap, but I think they alternate between the terms in this paper. But this was really interesting. I mean, it looked at almost 200 patients who had treatment for Kienböck's disease, and essentially looked at the outcomes whether they had a vascularized bone flap, and then also looked at other procedures like a joint leveling surgery, a PRC, or a wrist fusion. And I think I'd be interested to see how this informs your thinking about the treatment algorithm. But they did say that revascularization procedures tended to work better in patients with earlier stage disease, which I don't think is, earth-shattering, but it is helpful to kind of see the numbers. And then I think a PRC does pretty well in patients with late-stage disease. What were your thoughts?
I like the paper. And, when Steve came on this podcast, we talked a lot about this, both the technical aspects of it and his philosophy, which, I think his philosophy is now supported even more strongly by the findings of this 40-year look back. And it makes sense. Using it for early stage, using a vascularized bone flap or bone graft for early stage disease gives the potential for normalization of the bone and truly revascularization rather than secondarily treating the problem. So it's appealing intellectually. I think all of us know that the challenges of doing this procedure can be tricky. Inserting the bone flap, potentially enlarging the lunate by sort of stretching it, inserting the flap, keeping the, the vessel attached to the bone. I mean, I've seen it all. I think those of us who do this
Get that,
have.
get that, get that tamp out. You hit the wrong spot. Oops.
I mean, it goes back to one of the original procedures. Just take a blood vessel and dunk it in there. That's probably not ideal. So, anyways, clearly, this makes sense. The findings are aligned with common sense, which I always prefer. So, early stage disease. And it's just another reason to think about this procedure and potentially instead of a shortening of the radius. Now, that's an interesting concept because what I tend to do, which makes my data less helpful, is if I have a early stage team box and ulnar negative variants, I tend to do both. I shorten the radius by a millimeter and I perform a vascularized bone flap. And every patient does wonderfully. But I don't know which one helped. And they don't all do wonderfully, but most of them do well.
Right. And I guess I don't know if I didn't read it closely enough, but I'm not sure if any of those patients in this series had both procedures, because that's exactly what I would do. And so the question I had for you was, what's the role of an isolated, radial shortening osteotomy in the current practice?
Well, I think in Minneapolis, I'm not in Minneapolis, in Rochester, they would just do. I think they would just do the vascularized bone flap, and I think for most of us that doesn't make as much sense as doing both. So this paper doesn't change my philosophy in that regard, but I think it's again probably institutionally dependent. Um, yeah, I guess I would say. Although interestingly, I'm gonna have to edit this part, but interestingly, in their conclusions, they do say that we believe that vascularized bone flaps still have a role in the treatment of Kienböck disease, particularly in patients with early stage disease, those with neutral or positive variants, or in cases where DREJ anatomy precludes radial shortening. Um, Revascularization may be preferable. Revascularization may be preferable in younger patients because it doesn't preclude future salvage type procedures. Interesting.
Yes. I mean, so that was the exact point I was going to bring up is, the role of revascularization in the setting of somebody who's ulnar positive in particular. And I have not encountered a lot of patients with the DRJ morphology that is not suitable for shortening, but maybe it's seen me and I have not seen it. I don't know if I've truly scrutinized that enough. Although, if there's obvious deformities, they're gonna jump off the screen. They also mentioned that these revascularization surgeries are challenging in patients who have a coronal plane fracture, and that's an important thing to look at as well. And then I think you want to point out, like, if anybody goes to read this article, table three is great. Patients with more severe disease, if they get a PRC, they got pretty good dash scores. So that's notable in terms of, that's still a very reliable procedure. And then I think largely based on what the prior literature was, the PRC tended to be used in older patients, although we know based on evolving literature, including a paper from one of our partners, Lindley Wall, that PRCs can be safely done in younger patients.
Yeah, well summarized. So I think we have pretty good takeaways. And the point of our discussion today is not to spoon feed you listeners the takeaways from the manuscript, but honestly is to encourage you to take a look at the manuscript and draw your own conclusions. I think it's thought provoking. It's helpful to justify the use of this procedure in the right patient.
Okay, so let's move on to our next one. You want to take the lead?
For sure. This one I thought was interesting. It's a classic paper from my friend David Ring, even though he's a middle author, so I'm not sure where he was in guiding it. But this article is the title is long. Bear with me. Do patients older than 40 years with work claims for unilateral wrist symptoms have symmetric bilateral MRI signal changes that do not correspond with symptoms? And so the question is one that is an interesting one. Like, what do you do with the older patient, perhaps that's my age or older, with unilateral wrist pain and the potential that if you obtain bilateral MRIs, the other MRIs showed findings as well?
They explained it very well because I'm sure reviewers were like, "Why are you getting bilateral MRIs?" But apparently, it's the routine practice for this work comp doctor. I don't say that in a pejorative way, but it's somebody who mainly sees worker related injuries and does get bilateral MRIs. Maybe there was something that put I think it's Dr. Tan, who is the work doctor, something that put her onto this. Have you seen that as routine practice in any extremity situation?
One thing I can tell you for sure is in the great state of Missouri, there is no way that bilateral MRIs would ever be approved by work comp. I mean, some of us have trouble getting a unilateral MRI approved for work comp, and work comp is a good player in the state of Missouri, but I could never get bilaterals done, which is what made me, interested in the findings here.
So I guess it may not relate to our practice in Missouri and Illinois, but it is interesting. There were a lot of, I guess I'll say, incidental findings that may or may not actually relate to where they're having pain and what their injury is.
Yeah, I mean, part of this is intuitive. I mean, that there is old literature with the TFCC that basically says it's kind of like bulging discs. I think we all understand that as we age, the quote unquote normal anatomy changes. And so we know that if you're my age and I MRI both my wrists, in all likelihood, I'm going to find a tear of my TFCC or an irregularity.
Senescent findings, as they say in this paper. Age-related senescent findings in
I thought
the
you were going
gold
to say
bar's wrist.
convalescent. Am I
Con-
convalescing yet? So their
take you out back,
findings.
Chuck.
It's getting close. Um, it so it's not surprising, but the flip side is kind of how do you think about that? So, okay, the right wrist is painful, the left wrist has findings as well as the right wrist, but you still have a patient. The real question is this is a work injury situation. And so, do the MRI findings correlate with pain? And correlate with the reported injury from work, and then how do you address them? I think it's just my takeaway is um, just because you have MRI findings, don't overinterpret those. Don't screening MRIs for me for wrist pain, just like a diagnostic wrist arthroscopy for me doesn't usually make sense. I MRI to get information, but usually to confirm a suspected diagnosis or guide a potential intervention. I don't do screening MRIs almost ever.
With nerve tests, I mean, it's an extension of the physical examination. You should have a pretty good sense of what is going on with that patient before you send the MRI, and maybe that's just kind of stubborn old school doctoring, but It should, inform what you're going to do and confirm your suspected diagnosis. I think that if you look at what the actual findings were on the MRIs here, half of them were ganglions. So if the patient doesn't have pain in that area, clearly that's not relevant. And then the other most common finding was arthritis. So, while the findings are frequent, you have to correlate that with your physical examination.
Yeah, that's right. The other interesting thing about this is for those earlier in their practice who are interested in contributing to the literature, considering non-typical either evaluation practices or treatment practices can be really helpful. And so, for whatever reason, the bilateral MRIs existed for a large group of patients, and they took advantage of that fact with this study. And I do think there's value there. Of course, standardization of these kind of steps, whether it's evaluation or treatment, is certainly how we approach things. But there is clear disagreement. There's personal choice in orthopedic surgery and hand surgery. And so, how do you consider those choices that we make every day and those decisions, and how can we learn from those? So, that's another reason I like this paper.
Yeah, absolutely. I think it's a savvy research methodology, and Dr. Ring never disappoints in terms of opening our eyes to new ways of thinking.
Yeah. All right. We got three more. Your choice. You're up. Pick one.
I'll leave it. I'll present the next one, but I'll leave it up to you whether we want to do all three next, or do you want to save some of this for a cliffhanger into the next episode?
I think we can knock them out in a very effective and efficient way.
So I'm not going to bias the listeners too much, but I read this article with a healthy dose of skepticism. This is an article from a group of surgeons in Tokyo looking at anatomical reconstruction of terminal tendon and lateral band for severe chronic tendon mallet injury. So they looked at 11 patients who had a chronic mallet, and they took the palmaris longus and folded it over and inserted it with an anchor into the distal phalanx. So basically at the insertion of the terminal tendon, and took those two tails almost like a Y and ran those along the lateral bands. And then anchored them into the proximal phalanx, sutured them to the lateral bands at the level of the proximal phalanx. Um, they were able to get good results in terms of active extension of the DIP joint. I can't say that I'm going to be signing anybody up for the surgery anytime soon because it does seem like a long run for a short slide when you've got other effective options. What do you think?
Well, congratulations to them. New techniques or slightly, different techniques are always inspiring to me because there is that creativeness required to execute on this. So that's awesome. They've been doing this for a long time and clearly have been satisfied with their results. My partner, our partner, Marty Boyer, historically loved to reconstruct the spiral oblique ligament, which in every anatomy session we do every year, twice a year, the residents look for it and can't find it. And this
Oh
article's
no, they tell us
different.
they tell us they find it. We
They do.
ask
And we
them.
all look.
Half of them tell us they found it. The other half are like, we couldn't find it. You're like, you're right. You
If
can't because
if
it
I
don't
remember
exist.
correctly, you're always supposed to look on the radial side of the ring finger because it's best there. Anyways, yeah, it's an interesting technique. I guess and Marty stopped doing the spiral oblique ligament reconstruction because A, it's very technical and time consuming, and B, most of us think there are simpler options, whether it's central slip release or fusion of the DIP joint, depending on a variety of factors. The other thing technically which struck me, and the pictures they have are very nice, is they passed the split palmaris longus tendon underneath the transverse retinacular ligament. Um, that ligament is real, but the space beneath it is not a lot. So I wondered how they did that, but I haven't tried it, so maybe it's doable, or clearly it's doable.
Yeah, I mean, you're very diplomatic in how you've approached this. I do think it's impressive that they've accumulated this number of patients, and their patients have done very well. So that while this is not something that I'm going to be clamoring to do, technically it seems very challenging. If it works in their hands, fantastic. I will say that, chronic mallets oftentimes will end up being treated non-operatively and counseled appropriately. I think Marty talks about how your introduction of that central slip tenotomy under local anesthesia has been one of the biggest changes in his practice, in over decades. And he definitely credits you with showing him, the light on that. I just haven't seen that patient come up that often. I haven't been doing this as long as you have, but it just doesn't come up that often for me.
Well, they were very clear about the severity of the mallet. This wasn't someone with a 10 degree, not that you're saying it was, but it wasn't someone with a 10-degree or 20-degree lag. This was, I think, average
These
was
are like,
nearly 50
yeah,
degrees.
50-degree lags, which is real.
Yeah.
Do you find that that actually bothers patients unless
Yeah,
they
I
have
think
an accompanying swan neck?
I think it does, honestly. If it's that degree, I think it does. And the patients that I see, of course, we don't know what we don't see, but the patients that I see are coming in for a reason, and even counseling that you'll be fine doesn't seem to work. So I do think something is often helpful. Again, and my two choices, depending on the severity and the patient, are that central sublunar or a fusion.
Yeah, I guess I should contextualize some of my comments earlier about how about counseling. Is I just don't see this patient, and
Yeah.
or they don't see me. Like maybe there's a billboard that says Dr. D does not want to see chronic mallet deformities, which is great, but this doesn't come up for me very often. So
All right, let's do something that might come up for you often, which is the paper looking at trigger finger release. Um, so this is a study out of the Rothman Institute. The lead author is Dr. Pohl, POHL, and the title is Incidence and Predictors of Subsequent Triggering Requiring Treatment After Trigger Finger Release. So this is a large cohort over from 2015 to 2017. And they found that 40% of patients required subsequent treatment with either steroid injections or surgical release, either in the same finger or additional fingers. And most of these were in additional fingers. But I think it's just a nice summary for patients because we get this question all the time. Am I going to get it in other fingers? Am I going to have additional treatment? And the answer is, yeah, probably so. There's a really good chance you're going to have this addressed in other fingers. And occasionally, and we all know this, we've talked about this on the pod, that trigger finger release is a really, really good procedure. But like other procedures, it's not perfect. And occasionally, postoperative injections or revision releases are required.
I love this paper because for the exact point that you just made, I have numbers now that I will quote to patients. You have a 2% chance of needing a steroid injection even after the release. You have a 1% chance of it coming back in the same finger. You have a 1 in 8 chance of it affecting your other fingers. Great. Numbers. Perfect. Helps me, guide the conversation because those are, like you said, those are the things that people ask about. And I oftentimes just have to say, yeah, it's as close as we have to a cure, but there is a small chance it could come back. Now I've got a number.
Yeah. And I think that's it. I mean, I congratulate the authors. This is not a small amount of work to review, and even with a well done study, we know that there's probably patient leakage and et cetera, et cetera. Doesn't matter. Well done study, helpful perspective, and something that you and I will both quote in our clinics moving
Yeah.
forward.
It'd be nice if you could look at people who actually go to somewhere else, and if they end up in a different clinic in a different state, a different part of the city, et cetera. But even with your large administrative data studies, you're not going to be able to do that because there's no way to code for even laterality is a challenge, but coding for specific fingers is always, introduces a lot of variability for injections and for surgery still. So, all right, let's go to our last paper. Let's
Number
see.
five.
Number 5. So this is the dermal allograft augmentation paper from Cedars-Sinai in Los Angeles. Carol Lee is the first author. Ty Lee is the last author. Steve Shin's on there as well. Dermal allograft augmentation with PRC, a biomechanical study. So the thought here was that when you do a PRC, you're altering the mechanics of the wrist. You're changing you're decreasing the contact area and then inversely increasing the contact pressures. And the thought is maybe putting in a dermal allograft can help get the contact pressures closer to the intact wrist. And then if you're going to do a single layer, why not do a double layer? So this was a biomechanical study that looked at that, and essentially they demonstrated that doing a double layered dermal allograft does reduce the contact pressures and gets you closer to the joint mechanics of your normal wrist. But obviously, reading the paper and looking at the figures, it seems like a very technically challenging thing to do. What do you think?
Yeah, super interesting. It's funny, in our hand conference this week, we discussed this very issue with interposition of different things, including meniscal allograft and capsular interpositions, which is my personal choice, but not for every case. Um, again, I like this paper because it addresses a problem. The question is, does it address a problem that has clinical implications? And so the problem that it addresses is we know because the arc of curvature of the capitate and the lunate are different, that there will be arthritis which develops over time after a PRC. The issue is those are not all symptomatic. In fact, the minority are symptomatic. So this is addressing a problem, and it is a nice way to think about the biomechanics of the arc of curvature of the capitate and the lunate facet of the distal radius. I think technically, maybe not super straightforward, but also probably not terrible. Don't know that I want to do this necessarily, but I like that they raise this issue. And more importantly, I like that they tackle this in the lab with a well done study.
Yeah, from a methodology perspective, it's about pretty straightforward. Pressure sensors, et cetera, and it's done in a very iterative and appropriate way. I guess the question for me is, you mentioned taking capsule, for your interposition technique. They mentioned in their article that, perhaps the capsule is not in great shape in some of these patients as they get older. And then I think that PRCs perform pretty well, both in the literature and for all of us individually. I think most of us can make that procedure work pretty reliably. So I'm not seeing a big number of patients down the line with post-PRC radial carpal arthrosis, symptomatic. Maybe I just don't do enough of, I don't have enough of a PRC volume and population to see that. The only other thing I think maybe this could have some relevance for is if you have the patient with a little bit of wear on the base of the capitate, does doing this dermal allograft then liberate you to use to widen your indications for a PRC?
Well, I think it does. The other thing the literature has absolutely taught us is that PRC has a lower complication profile and generally as good or better outcomes compared to scaphoid excision and four corner fusion. And most of us are limiting our use of the scaphoid excision and four bone fusion to very selected younger patients. And so if we can expand the usage of the PRC, that's great. Yeah, I mean, first of all, I think it's fair, but not 100% accurate to say the capsule may not be ideal in these patients. But in general, I think it is. It's just fine. And it's interesting. I don't know what the cost implications of this procedure are now. If you save the patient another surgery, the cost implications are great. But if you don't, you're looking at a couple of suture anchors, you're looking at the graft itself. So it's an important consideration. But again, it might be the right solution for certain patients.
Exactly. I think that's very appropriately stated. And just for completeness sake, I think that the conflict of interest should be disclosed here that, the research was supported by the company that makes the allograft and the anchors. So something to keep in mind doesn't mean that the findings aren't valid. It's just something to contextualize how you interpret the article.
Absolutely. Well, as usual, this was fun. Love the articles, and hopefully it'll encourage our listeners to go pick up their journal of hand surgery, whether physical or online, and take a deeper look at these articles.
Yeah, and we did get some feedback that people who aren't in academic settings liked having the last episode as a way to engage with the journal and kind of reminded them of journal clubs when they were in training. I will say that I recently took a long road trip with my father and brought the three latest editions of JHS print with me, and sat in a hotel room and just kind of looked through them. And it was nice to kind of look through a physical journal again. But who knows if that's going to continue in terms of print journals because obviously the world is changing.
World is changing. Have a great weekend.
Yes, you too. And listeners, please send us additional questions, topic suggestions, handpodcast@gmail.com, and everybody enjoy your day.